Mara Thomas, content editor for Urban Health Today, and I'm speaking today with Dr. Nathan S. Bryan, founder and CEO of Nitric Oxide Innovations, and Dr. Michael A. McGee, an emergency room physician, managing partner and CEO of Premier Urgent Healthcare in South Side Hyde Park, the clinical medical site for Chicago, Illinois. They're going to be speaking with me today about the first oral system nitric oxide-based therapeutic specifically for African Americans with COVID-19. Clinical trials are already clear to begin. So let's get started. Through your research, you learned that diminished nitric oxide production is a driver for higher risk of COVID-19 infection in Blacks with comorbidities. What are the effects of diminished nitric oxide in the human body, and why is this important?
Well, thanks, Tamara. I'll take that question. Yeah, so everything we've learned about COVID over the past 10 months points to a deficiency of nitric oxide from the increased risk of infections in susceptible populations such as the African American population. But it also explains the rapid progression of disease, need for hospitalization, ventilation, and increased death and mortality in the African Americans. So the African American population in general, we know from many years of known health disparities and 30 years of research that they make less nitric oxide than the general population or the white population. And that actually explains the health disparities, the increased incidence of high blood pressure, diabetes, heart disease in the African American community. So when you see an African American person, an older patient with these underlying comorbidities such as high blood pressure, diabetes, kidney disease, lung disease, or heart disease, that is exactly the population that's at an increased risk of infection and rapid progression of disease due to COVID. And so the design of our study is to take this very susceptible population and begin therapy early in the disease process within 72 hours of a positive test, begin the therapy, and hopefully prevent the progression of disease and the need for hospitalization.
What did you learn about the relationship between nitric oxide and the coronavirus specifically?
Well, we know that part of the innate immune response, whether it's coronavirus or any viral or even bacterial infection, is mediated by nitric oxide. So when we get exposed to viruses, and by the way, all humans are exposed to all different kinds of viruses every single day of the year. The typical response for healthy people is their immune system recognizes this infection, mobilizes the blood system and the immune system, and then our white blood cells generate a lot of nitric oxide to actually stop viral particle replication and preventing that virus from replicating and spreading throughout the body. So when your body is deficient in nitric oxide, you don't elicit an immune response, you have compromised blood flow, and yes, our own innate immunity and our ability to kill off the virus is compromised. And then you allow the virus to replicate, you allow it to spread, causes inflammation throughout the body, and that's really the etiology of disease, as well as explains the acute pulmonary distress syndrome, the inflammation within other organ systems, the kidney disease, the increase in blood clotting that we're seeing in active COVID patients.
You know, Tamara, just to add to that, in addition to what Dr. Bryan just said, I do want to add the fact that coronavirus is such a novelty in terms of what it does to the body, is that even today, we're finding out every day different things that occur if you get it. For instance, not only do you get what Dr. Bryan just said in terms of the COVID storm and the respiratory distress that compromises you, but also you're at risk for getting clots and DVTs and strokes. As an ER physician, which is my first job, I've had 30-year-old men come in with no risk factors for strokes and end up having a stroke that was caused by coronavirus. And what he's saying is this new drug also prevents the endothelial damage that's caused by coronavirus that makes one susceptible for getting clots and strokes. So if you can prevent that from happening to someone who's at high risk, then you're making a huge difference. The other thing is you're having long haulers, you having, just 2 days ago, Lancet Psychiatry is saying that 1 in 5 people who get COVID are also having some mental illnesses that are popping up several months later. And so this particular virus is scary because you don't know from one day to the next what effect it can have upon you. Sure, you can be the 85% who get it and do well, but then you also can have these long-term complications. In addition to that, cardiologists are seeing that 21% of people who have COVID later can get atrial fibrillation, about 10% can get kidney disease, and about 15% can get congestive heart failure. And so once you get past the initial symptoms of it, you're still at risk later for further complications. So a drug like this that could prevent all these different things from occurring is definitely needed.
So did your work look at other non-white groups like Latinos or Southeast Asians for signs of efficacy? And what did you learn there?
Well, we look to where the data and the science take us. So we know that the Hispanic population and Asians have an increased risk, just like the African Americans. But we chose to go with the African American population because there's more evidence on the etiology and the mechanisms of the health disparities, specifically in the African American population. There's dozens of studies published on endothelial dysfunction, lack of nitric oxide production, specifically in the African American population. So we went to this highest risk group or susceptible group because what we know is that the underlying physiology is exactly the same across all ethnicities. If you have endothelial dysfunction and lack of nitric oxide, it leads to inflammation, increase in blood clotting, increase in heart attack and stroke, and all the things Dr. McGee listed. So if we can correct the nitric oxide production in this specific high-risk African-American group, it'll work across all ethnicities. But we went with the African-American because there's really a preponderance of data explaining the health disparities outside of the COVID world, but also the increased risk and hospitalization in the African-American community from COVID.
So,
and Tamara,
yes,
this is widespread. I'm sure, as you know, African-Americans, throughout history have had the highest health disparities in terms of everything from diabetes to hypertension to kidney disease to all the things and comorbidities that make COVID susceptible to killing them. And so in terms of, you look at cancer, we have the highest, mortality rate and the lowest survival rates for cancers. And we also are the least to be included in clinical trials. And it's been long stemming from that desire to not be in these kind of studies. And 69% of African Americans have never even been asked to be in a clinical trial to even have the advantage of surviving their illnesses. And so studies like this are needed in every health disparity population. And so I welcome the opportunity for people to learn about this and others. And also the National Institute of...
I just wanted to piggyback on that for a second and say that, I have signed up for several clinical trials over my adult time, and I have never gotten called for not one, and I'm not high risk. I don't have comorbidities. I would think that, with the lack of African Americans, in studies, that I would be a fine. And yet here I sit today and I have signed up for so many and I have never, ever gotten a call for not one. So I just wanted to attest to what you said. Go ahead, sir.
Well, I think that's congratulations to you because you're probably obviously healthy and maybe don't fit the inclusion criteria for many clinical trials. Clinical trials are designed to test both safety and efficacy in specific populations. And so if you don't fit that inclusion criteria, then you probably won't qualify for those clinical studies. But thank you and congratulations.
But even for the COVID vaccines, I signed up for clinical trials because, there's this big push allegedly for more diversity. And I haven't gotten called for any of those either. So,
it's never too late. You may get a call when you least suspect it.
Well, we'll see. What other therapeutic applications can this be indicated for? Is it just this one virus, or could this be applied to other viral infections?
Yeah,
well, traditionally, I'll tell what I know, and then Dr. Bryan will tell you all the new things that he's been working on. Even I have twin daughters. They were born at 24 weeks. Nitrous oxide was used on one of my daughters to prevent pulmonary hypertension and to get her off the vent as a preemie. And so nitrous oxide has been around for years. In addition, we use it for anesthesia. It works well. As you all know, anybody with chest pain who comes in, the first thing that EMS and me as an ER doc is going to give them is a nitro if they fit the criteria. And nitro is a derivative of nitrous oxide. It vasodilates the vessels so that the blood can flow to the heart to decrease the attacks of the heart attack. And it thereby gives blood flow to the heart to improve circulation and oxygenation of the heart. And so it's been around for years, but Dr. Bryan can tell you some of the new things that are going on that I did not even know about.
Well, when we develop, rationally develop safe and effective therapeutics, we try our best to recapitulate physiology, what normally happens in the human body. So as I mentioned earlier, part of the immune response is to mobilize your immune system, isolate the infection, whether it's viral or bacterial, and generate a lot of nitric oxide that shuts down both bacterial respiratory virus particle replication. So viruses are pretty much all the same. I mean, there's certain classes of viruses, but our immune system deals with them all the same. So we think this will have enormous clinical utility, not just in coronavirus or COVID, but even in the seasonal flu. Seasonal flu is really no different than coronavirus. The symptoms may be a little bit different, but the underlying immune response is the same. And it's the same susceptible population that gets the flu, that's hospitalized from the flu, and that eventually succumbs to the flu. And so it's older people, African Americans with underlying comorbidities that do very poorly. On the contrary, somebody like me, I haven't had a bacterial or viral infection in over 20 years. It's not that I haven't been exposed to viruses, it's just that my body is robust, that when we're exposed to it, our body isolates it, kills it off, and we never have symptoms from it. So I expect that if this drug study is successful and we get drug approval, that it won't be used just for coronavirus. It can be used even prophylactically for seasonal flu or any other unpredictable virus that may come our way from anywhere at this point.
Forgive my ignorance, but there's also the angiotensin converting enzyme that the virus uses, right? I don't know that the flu also uses that pathway to enter and proliferate the body.
No.
Can you talk about that a little bit?
Well, I think there's still a little bit of controversy on that because this particular virus uses the ACE receptor as a ligand to attack human cells. So historically, coronaviruses didn't affect humans, but there's still some discussion on how it got a receptor binding sequence to attack ACE receptors. And so you bring up a good point that patients that are on angiotensin converter enzyme inhibitors, ACE inhibitors, or ARBs, these receptor blockers, have seen an increased risk of infection from the coronavirus. And so in a joint statement from the AHA and American Heart Failure Association and AMA recommended that cardiologists at least consider a different class of medications that are on ACE inhibitors or ARBs. If you normalize nitric oxide levels, then that's necessary and sufficient to fight off not only the viral particle infection, but the rapid progression of disease that we see in oxide deficient patients.
Okay, thanks for talking about that. So your study requirements are for African Americans with comorbidities with an early diagnosis of COVID-19. Why is the 72-hour window crucial? Can you talk about that?
Yeah, I can take that, and Dr. McGee, you can add on where you feel fit as a physician who treats these patients. Our scientific rationale is that if you catch the disease early in the process, there becomes a point where you can intervene and basically stop its progression. And I think Dr. McGee would probably agree with me. There reaches a point in every disease process where you reach a point of no return. And we've known now for 10 months that chronically ill patients from COVID that are in the ICU on ventilators we've used inhaled nitric oxide very successfully to basically match ventilation to perfusion, overcome the acute respiratory distress syndrome. But we don't know what the survivability is on those data because these are already chronic patients that have progressed to the level of ventilation. And once you get on a vent, your prognosis is very poor. So we understood that science to the extent that if we catch it early enough, we can implement this therapy and actually get it. And this is an outpatient study, which I think is very important. So we're catching it early on, very mild symptoms to see if we can prevent that. Whereas all other studies, most other studies are at inpatient. So once you progress to the extent that you need a hospitalization, then most therapies are implemented in the hospital. The beauty of this trial is if we can catch the process early on and start therapy, we can prevent hospitalization. Dr. McGee will attest that during these spikes, hospitals, emergency rooms are stressed because they run out of beds and resources to treat these. So our best contribution, if these drug trials are successful, to eliminate that, treat the patient in an outpatient type environment and prevent the progression of disease to where they don't need to go to the hospital. That's my mission.
And yeah, I guess when scientists look at different data points, they have to come up with something that makes sense. And usually it's arbitrary. But in this case, everybody knows that once you've been exposed to coronavirus, within 4 to 5 days, you will eventually see some symptoms. So you want to get to that before it becomes to the point of no return. Typically, after 5 days, you will see symptoms. And usually within 7 to 10 days is when you will get into the worst complications of coronavirus, which is the respiratory problems that one would get. And also people have been known to get what we call silent hypoxemia, where they're looking good, they're talking to you, but I would have patients coming to the ER talking to me and looking great, but yeah, their oxygen saturation is at 89%, where normal is 99%. And typically when you get below 89 and 88%, you can oftentimes get altered mental status because you're not getting good blood flow to your brain. And so a lot of people who may have this may be at home and not know it and can end up getting altered mental status and end up dying at home. And studies have shown that did happen when coronavirus first came out, because a lot of people were being sent home from the ER because they looked great. The oxygen O2 sat was fine. But then if they went home and did not have an oxygen oximeter to measure their oxygen levels, how do they know when they're going to get bad or worse? And so that's the beauty of this study as well. Once someone enrolls in the study, we give them tools to monitor them. So they will receive a blood pressure cuff. They'll receive a pulse oximeter where you can measure their oxygen levels. And then they're being monitored by an outside entity on a daily basis to see how they're doing. And so the minute they start not doing well, they're instructed to go to the hospital and be admitted. And so a lot of people with coronavirus go home and they don't know what to do after that. In this study, they're being continuously monitored so that now you can watch for poor outcome or good outcome. And so that's the beauty of this. Not only do you get something that could potentially make a difference in your life, but it also prevents you and you also being watched over, because it's scary being at home, especially if you live alone and not knowing what to look for and not having the tools to even give you an idea that you're doing poorly.
I'm just thinking about something I read not too long ago about that most patients of color tend to wait longer to seek medical care when they have onset of symptoms than white patients. And so I'm just, wondering about the timing. Is there like an education barrier? Do more people need to be aware? What should they be looking for sooner to get, because 72 hours, look, if someone thinks they have a cold, let's say, or they've got a sniffle, or they've just got a sore throat, and then it goes from 0 to 60, but it doesn't take 72 hours, it takes longer than that. How do you get that patient in that crucial window? Do you worry
It's
about
actually 72 hours of being found positive
okay.
with coronavirus, not the symptoms. But what you're saying is 100% correct, right? And so this, again, has been longstanding, it's nationwide, and there are multi-factors for why African-Americans or any minority will wait to go get taken care of. And,
Right.
and it happens with any disease pathology. not just with coronavirus. They can have heart problems. They can have stroke symptoms. They can have cancer and blood in their stool and not know what to look for. A lot of it is due to lack of education or access, which we hear about all the time. If you don't have insurance, you don't necessarily want to go to a doctor or ER because you can't afford it. So insurance is first and foremost. If you don't have transportation, that's a problem. If you don't have a doctor in your area and you got to go to another whole community, that's the problem. If you haven't, have a good relationship with your doctor, because that's important, right? If you have a good relationship with your doctor and you're communicating about everything, then you're going to be more aware of your disease pathology and you will take the necessary actions. And a lot of people just don't have good relationships with their doctors as well. A lot of people are HMO or Medicaid. And so these doctors are churning patients out and they're not communicating with them. So the interpersonal relationship is not even there. And so people tend to have a fear of going to the doctors and a fear of what they may find. And so all those are factors that lead to patients not necessarily coming in when they should. And I'm an ER doc and I see people at the far end of the spectrum. And I wonder, how could you have waited with this mass in your rectum and you knew you were having constipation for 2 months? And they just don't always understand that it's important to seek care early.
But there's also the fear, and there's that relationship, right? With, back to what you were talking about. There's also that fear going and not being treated well. There's a bunch of factors, right? Why people don't go and get care right away is because they're concerned that, well, I don't feel comfortable there. I, heard that, my friend went there and they were treated very poorly, and so I'm not going to go there, right? I mean, there's that as well.
Well, what you're getting into is several things, right? That's been systemic for years. Number one, and me being an African-American doctor, when I graduated from NYU, tops in my class, I was the only Black male out of 44 residents, right? And ER is a competitive residency to get into. So number one, there's not a bunch of minorities who are going into the medical field. A lot of times we don't have the funding to even get us through this, and so now you don't have people that look like you. And so now you're concerned to go to that doctor because you may think that they're not going to treat you right, just like you said. And they may have had a situation treated right. And it's there, it's inherent. And so we have to overcome all those different things to make minorities, not just Blacks, Hispanics, Asians, whomever. A lot of people experience the same kind of fears that may prevent them from seeking good care. We just have to have, and even when it comes to clinical trials, there are not a bunch of minority researchers out there. So minorities may not understand what's best for them because they're not being spoken to by people who look like them. And so they're gonna refrain from being involved in these studies because they don't trust people. And it not only stems back from the days of the syphilis trials, but just even before that, it's been systemic for years. And people have had these bad experiences that comes back to haunt them now when they're needed the most. And now the National Institute of Health has a initiative to increase the number of minorities in these studies. And they're doing things to get people in, and people still not subjecting themselves to these studies because of all the things we just mentioned.
Yeah, so does the AMA. They have a push as well. Dr. Bryan, how does this differ from other over-the-counter nitric oxide products?
Well, the easy answer is this is going for a drug indication, and it's not an OTC. This will be a prescribed drug that would have to be administered under the care of a physician. So when you the difference in drug and dietary supplements is the claims you can make. So dietary supplements, really the only thing you have to do is demonstrate safety, that you're not providing any harm based on ingesting of supplements. Drugs are much different. The rigor and the economics of getting a drug to market are two different worlds apart. So not only do we have to demonstrate safety in the general population, we have to demonstrate efficacy for specific indications. So as I mentioned earlier, we have a 20-year history of safety around the clinical use of nitric oxide. The development of safe and effective drugs, nitric oxide-based drugs, even for things such as high blood pressure, heart failure, and many other unmanaged medical needs, have been slow to reach the market. So we think COVID is kind of our first entry into the market for nitric oxide. But there are many others. As I mentioned earlier, this ischemic non-obstructive coronary disease, which is on the rise, which there's no effective management for. We're seeing the efficacy in heart failure with preserved ejection fraction, pulmonary hypertension. I mean, the common denominator in any chronic disease is low blood flow, whether it's heart disease where you have obstruction or ischemia to the myocardium, whether it's Alzheimer's and vascular dementia, decreased blood flow to the brain, kidney disease, renal dysfunction, pulmonary disease. The common denominator in all these is decreased blood flow. And nitric oxide is what controls and regulates blood flow and perfusion to every tissue and every cell in the body. So if your body can't make nitric oxide, those cells and tissues become dysfunctional and diseases set in. So our specific nitric oxide is a drug. Dietary supplements are intended to treat, cure, prevent, or mitigate any disease process.
And I'm curious, why a lozenge as opposed to a capsule or a tablet?
That's a very good question, Tamara, and I think it's important to note that nitric oxide is gas. It's not a stable molecule that some other, drug targets or drugs may mimic. So what we try to do is, again, mimic nature and recapitulate physiology. And nitric oxide, when it's produced in the body, it's gone in less than a second. So the challenge for the past really 30 years is, how do you design a safe and effective nitric oxide technology that generates nitric oxide when and where it needs to be generated? And so it's not a pill you can swallow, because a lot of that nitric oxide metabolism and release is dependent upon stomach acid. And a lot of people are on antacids, proton pump inhibitors. And so we can't control how that response would be in the general population. So with a lozenge, we put it in the oral cavity to where we disperse and generate a known amount of nitric oxide in every single patient, whether they on any type of medication, whether they have hychlorhydria for other reasons, or if they've got a dysbiosis in their oral microbiome. We control and we dictate the release and metabolic fate of nitric oxide in every single delivery, so that every single person, whether you're Black, white, Asian, Hispanic, we get the same effect in every single person.
And Tamara, just to add to that real quick, even when we give nitro for patients who are having heart attacks, it dissolves under your tongue because you got better systemic absorption throughout your body. So it works quicker. And also, people don't like swallowing pills. You'd be amazed how many people come in the ER and can't swallow a simple tablet, and we got to crush it for them. So it's a good reason why it's something that can dissolve easily.
Well, that's good thinking on you guys' parts. I know that you're in Chicago. Is the study being done anywhere else in the nation?
Yeah, so what typically for FDA approved drug trials, they like a multi-center, double-blind, placebo-controlled study. That's the gold standard in clinical trial design. And so what we've done is we've gone to hotspots, primarily where African Americans, where there's a high degree of African Americans with COVID. Obviously, everybody who watches the news, Chicago has been a hotspot for COVID. We have a clinical site in Houston. We got a clinical site in Jackson, Mississippi, and the surrounding metroplex, and then also in Augusta, Georgia. And the great thing about this is with Dr. McGee and Premier Urgent Care is they have an active screening community. So, I mean, you brought up a good point earlier. People may have, we're entering the seasonal flu season. So people may have, upper respiratory influenza-like illnesses, and then just want to know, is this COVID or is this allergies or is this the seasonal flu? And so in Hyde Park at Premier Urgent Care, where Dr. McGee's screening, you can actually go in and we have rapid antigen testing to where within 15 minutes, whether or not you have COVID. And so Chicago is a very important center for us with Dr. McGee leading that charge, but we've got 3 other sites around the US.
Dr. McGee, you've made it your mission to recruit African Americans for these clinical trials. I'm wondering if you anticipate any challenges on top of what we've already discussed in recruiting the specific target audience you need.
Of course, there are challenges. And number one, when I first found out about it, I told Dr. Bryan that if I'm going to be involved with this, it got to be something that I believe in and have a good sense that it won't harm people. Because I have high integrity and I can't be used as a pawn to get people to do things that could hurt them or won't be effective, no matter whatever it entails, money, what have you. None of that is important to me. And so I did a good thorough investigation. I went and looked up Dr. Bryan. I looked up nitrous oxide, which I already knew a lot about. And I already knew that nitrous oxide had been around for years. And so now you have something that's not new, like vaccines, which, you know, they're producing things that we don't know what effect it's going to have on somebody. Nitrous oxide was used on my 24-week daughter. So I already had a good sense that it's a very safe drug if it's already and continuously being used on preemies. So already that's a good speaking point right there that, hey, it's safe. It's been here for decades. It's used on small premature babies. And so that right there in itself is something that you can easily expound upon when you're trying to convince people. Now, in regards to barriers, there's a lot of barriers that come from long-term fears for any clinical research. And right off the bat, there are three major barriers. One is personal, individual. The second one is system, and the other one is interpersonal communications. And so on the individual part, you have the patient who already has a fear, who may not have even been told about it, these kind of studies, because they're in an area that's under-resourced, so they may not even know. And then you have the physician who may not even be in an area where research is even being offered, because they may not even know what's out there. And so all those are factors. And then you have the family. You know, the family has to be on board, else they're going to convince the patient to not even be involved in the study. Then you get into the system part of it, and this is where you have hospitals that are more affluent with more resources that can offer these studies, but then where all the patients are located at who need the study. They're in underserved areas. They're in areas that don't have resources. And so they won't even know about this, or they're not privy to this kind of research because they just don't have the access. And then you get into the interpersonal, where the physician may have an implicit bias that we mentioned earlier. They may feel that African Americans are not the best candidate for this because they're not compliant. They don't do things expeditiously. And so they don't want anything to jeopardize their study. So they may not even ask them to be in the study. And then what's the communication like? How is the information being disseminated to let African Americans know they can be in the study? Is there marketing? Is there, are they on everyone's favorite radio station? Do they have, Black docs who look like them being the voice or spokesperson for getting them to be in these studies? So all those are barriers that if we can overcome those by using a multi-level approach, holistic approach, you can now induce and increase your number of representation for minorities. But it definitely takes some funding. It takes some innovative actions, and it takes a bunch of marketing in areas that Black people or Hispanic people, whomever, are there. Because otherwise, they're not going to come to you because they don't even know to come to you. So you got to go to them. Yeah. So I think we're working on that right now. We're doing some innovative things in terms of reaching out to social media influencers, trying to get Dr. Bryan to get us on several different major radio stations. We definitely got to get some interviews on some TV networks. But the reality is time is of the essence, because the number of people who were supposed to be in the study is only 840. And you already got 4 cities being involved. So if those other 3 cities have 700 people already enrolled, then Chicago is going to be on the losing end of it, because now even though we're able to get 400, that's our max. If we don't get 50 and 750 patients already gotten, then we won't be able to get anybody. It won't be a benefit of us. So that's why interviews like this and networking and media is important to make people recognize, hey, you need to get in on this right now while you can. And so that's what we're trying to do. So thank you for allowing us to do this interview today.
Yeah, it's very, very good. Tim, I just want to add one important point.
Mhm.
here, and he reminded me of this, but this is a therapeutic. It's part of the coronavirus treatment acceleration program. This is not a vaccine. And I think it's very important to describe that differentiation, because it's known that up to 50% of the general population in the US isn't in favor of a vaccine, especially a vaccine being forced upon them.
Yeah.
So this isn't a vaccine, this is a therapeutic, and a therapeutic that basically recapitulates what the body would normally do, a normal healthy body would do. I think that's a very important point. Safety and efficacy are at the utmost importance of any therapeutic.
Yeah, the Operation Warp Speed is already causing distrust among the community, and no one wants to be the first to be involved in something that's being fast tracked without all the safetiness of it. And that's the beauty of this. Like you said, this is the therapeutic. It's been around for years. People have heard about nitrous oxide. They've heard about how many African Americans have had nitro under their tongue from having chest pain, and so it's something that they can wrap their hand around or their mind around a lot easier than these new vaccinations that are out there that you couldn't even get into the study with.
That just brings up a question for me. So you guys are familiar with the term long haulers. These are people who've had symptoms for a long time and they're not dying, but they're not getting better. I wonder your opinion, and this is strictly your opinion at this point. Do you think that NOviricid would work for long haulers?
So it's both my opinion, but my opinion's corroborated by over 160,000 published papers in the scientific literature. So I'm trained as a biochemist and physiologist. So I understand the mechanism of disease to the extent that we can correct it. And so again, it goes back to the body is designed to heal itself, to deal with an acute infection and then repair it and then get back to doing its normal business. All of that is mediated by nitric oxide. But if your body is compromised in its ability to generate this important molecule, the body doesn't repair, the body doesn't regenerate, and you have these nagging, prolonged symptoms. And so again, all of those symptoms can be explained by ischemia, hypoxia, which is basically reduced blood flow and reduced oxygen delivery to cells. All cells need nutrients and oxygen to metabolize and do their job. So if we correct the nitric oxide production in these patients, these long haulers, we expect to see an amelioration of symptoms and get on with the business. That's how the human body is designed to work.
And that could be a part of the second clinical trial that could come out. But also keep in mind, people are now getting reinfected again, and it's coming back much worse. And so after your 3-month antibody immunity time is over, that's when COVID is in your system and you're prevented from getting COVID again. Typically, it takes about 3 months for those antibodies to wind down. And at that point, you're back susceptible again. And people are having more virulent strands where they're much sicker. And so these are also other indications for why this drug can be of use.
Final question for you. I know I've taken up so much of your time. You guys have been super gracious. How can doctors quickly get their patients into this study?
Well, Tamara and Dr. McGee, we've created a landing page that's probably going to be live this week, tomorrow. And it's www.aacovidstudy.com. So we'll provide basically all the information on the etiology of coronavirus, the health disparities of African Americans, what to expect if you decide to join us and enroll in the clinical trial. We're going to hold your hand day to day. We're going to send you home, as Dr. McGee said, with a pulse oximeter, blood pressure cuffs. You're going to get daily phone calls from following up on you, checking up on you. So we're going to provide all that information on that website. It's aacovidstudy.com. And then, as Dr. McGee said, we expect to have some nationwide media coverage in the next week. We'll do radio, print. We need to get this information out to the African American community, because not only could it potentially save their own lives, but it could give us enormous information and save millions of African American lives that are unnecessarily and unduly suffering from not just coronavirus, but many health disparities.
They can also Google Premier Urgent Care in Hyde Park, and they can go to our website, www.premierucchicago.com, premierucchicago.com.
Thank you so much. This has been completely informative. This is really important work that you're doing. And it's high time that we have something that specifically addresses the concerns and frankly, you know, the detriment this disease is having on the African-American community. So I thank you for your work. I thank you for your time, and hopefully, you know, I can talk to you guys later, you know, again, as the study progresses and you get closer, you know, and
Please do.
Thank you so much.
please. Thank you so much.
Thank you, Tamara, and the great work you do.
Take
Thank
care.
you.